Welcome to the deep dive. Today, we're getting into something really fundamental to health, immune disorders.
Absolutely. It's a critical area.
Yeah, and our main guide here is a chapter from a nursing review text. We're aiming to go beyond just, the basic definitions.
Right. We want to pull out the really practical stuff, the core nursing concepts, assessment, procedures, safety, right, those priority actions.
Exactly. Like a focused look at what nurses really need to know when dealing with these conditions. Think of it as getting straight to the essentials.
Couldn't agree more. The immune system itself is just, well, it's incredibly complex, isn't it? It's our body's defense force.
Right, against germs coming from outside, but also cleaning up internal messes like damaged cells.
Exactly. And this deep dive is all about what happens when that system goes wrong, leading to these disorders. Understanding this is, I think, crucial for anyone interested in health. We'll try to break it down.
Okay, so the source starts with the basics, the immune system's main jobs. It's like a two-part mission, yeah.
First, protecting us from microorganisms, bacteria, viruses, all that trying to invade from the outside.
And second?
Second, dealing with internal threats, getting rid of dead or damaged cells, basically keeping things tidy inside.
Okay, that sets the stage. So how does it actually do all that? That gets us into the immune response itself and T and B lymphocytes.
Exactly. Those are the key players. There's specialized white blood cells, both made in the bone marrow. Then they travel to lymphoid tissues.
And they just hang out there.
Pretty much, yeah. They stay dormant, kind of inactive, until they get a specific signal to wake up and act.
Like highly trained specialists waiting for the call. And for B lymphocytes, the source says when a specific antigen shows up. What's an antigen again, just quickly?
Think of it like a unique ID tag on a foreign invader or substance.
Gotcha. So that antigen triggers the B cells to, rapidly multiply.
Precisely. They ramp up their numbers to launch a defense specifically targeted against that antigen.
Okay, and then there are the T lymphocytes. It's not just one type.
No, it's a whole team. You got helper T cells, suppressor T cells, and cytotoxic T cells, sometimes called cytolytic.
Helper, suppressor, cytotoxic.
Right, and they all have distinct roles, but they need to work together, coordinated, for a normal, effective immune response.
Okay. Now, the chapter then talks about two main types of responses, humoral and cellular. Humoral is described as immediate.
Yeah, humoral is the quick one. It's really good against acute infections, things that pop up fast, like many bacterial and viral infections. It's that first, very specific antibody-driven defense.
Right, quick reaction force. Then there's the cellular response. The source calls it delayed or delayed hypersensitivity. How's that different?
Well, it takes longer to get going. It's more active against infections that develop slowly, certain bacterial ones, for example.
Okay.
But it's also really involved in other things like autoimmune responses where the body attacks itself, some kinds of allergies, and even rejecting transplanted organs because the body sees them as foreign.
So humoral is like the fast antibody wave. Cellular is more. Cell-to-cell combat takes a bit longer to organize.
That's a good way to put it, yeah.
Okay. Then the chapter shifts to types of immunity. Innate and acquired. Innate is the one we're born with, isn't it?
Exactly. Innate or natural or native immunity.
Right.
It's there from birth. It includes physical barriers like our skin, biochemical barriers like enzymes in saliva and tears, mechanical things like cilia in our airways, and the inflammatory response, that immediate redness, swelling, heat at an injury site, that's part of innate immunity too.
Our built-in security system.
Yeah.
Then acquired immunity that develops over time.
Yes, acquired or adaptive immunity. We get it as we encounter things. It can be passive, meaning we get antibodies from somewhere else.
Like from mom.
Yeah, like a baby getting antibodies from its mother, or through an injection of antibody-rich serum, or even from the antibodies we made during a past infection.
And the other way is active acquired immunity through immunization, which the chapter notes is covered elsewhere. So innate is built in, acquired is built up or received.
Got it. Let's move to lab studies, crucial for diagnosis. First, the anti-nuclear antibody, ANA test. What's this one for?
Okay, the ANA test. It's a blood test, mainly used to help diagnose autoimmune rheumatic diseases. It's looking for antibodies that mistakenly attack parts of our own cell nuclei anti-nucleoprotein factors.
So antibodies attacking self.
Right, and the test also looks for certain patterns that often show up in different autoimmune conditions. A positive result, a titer, is really common in systemic lupus erythematosus, SLE.
Lupus, belly-white.
But it can also be positive in other conditions like scleroderma or rheumatoid arthritis, and sometimes even in healthy people. So it's a clue, but not definitive on its own.
Right. A positive ANA is a flag, but just one piece of the puzzle. Then there's the anti-dsDNA antibody test. That's anti-double-stranded DNA. Sounds more specific to lupus.
It is, yeah. Anti-dsDNA is much more specific for SLE. It identifies antibodies targeting DNA itself. So this one's better for confirming lupus.
It definitely helps support the diagnosis. It's also useful for monitoring how active the lupus is, how treatment's working, and even gives some idea about the prognosis. So yeah, if ANA is broader, anti-dsDNA is more targeted for lupus.
Okay, that makes sense. Next, the chapter goes into HIV testing. Several different tests here, starting with the CD4 plus T cell count. Why is this one so important in HIV?
Because HIV specifically targets and destroys these CD4 plus T cells. They're absolutely vital for a healthy immune response. Remember the helper T cells.
Right.
So as HIV progresses, the CD4 count goes down, and that directly reflects how weakened the immune system is becoming. The chapter gives some key ranges.
Yeah.
Normal is usually 500 to 1,600 cells per liter. Immune problems start showing up more often between 200 and 499, and below 200, well, that indicates severe immunodeficiency, which is the threshold for an AIDS diagnosis.
Wow, those numbers really show the damage. The chapter also mentions the CD4 to CD8 ratio. CD8 cells are another T cell type. How does the ratio help?
Yes, CD8 cells are another important T lymphocyte. Normally, we have about twice as many CD4 cells as CD8 cells, so the ratio is around 2 to 1.
Okay.
In HIV, as CD4 cells get destroyed, that ratio often flips, sometimes going below 1 to 1. So watching that ratio change gives another angle on the immune system damage.
Interesting. Then there's viral culture, viral load testing, and the P24 antigen assay. These sound like they measure the virus directly.
Exactly. Viral culture tries to grow the virus from blood or tissue. Viral load testing is very common. Now it measures the amount of HIV's genetic material, RNA usually, right in the blood. High viral load means more virus activity.
And P24?
The P24 antigen assay looks for a specific protein, P24, which is part of the core structure of the HIV virus itself. So yeah, these directly assess how much virus is present, which is key for seeing if treatments are working.
And the chapter mentions oral and home HIV tests too. Making testing easier to access must be a huge help.
Oh, absolutely. Huge impact on accessibility. The oral test uses a swab on the gums or cheek to look for antibodies. A positive result always needs a follow-up blood test, though.
And home kits.
Same idea. Allow for initial screening privately, usually with a blood spot or maybe a rapid device. But again, any positive needs professional follow-up for confirmation and counseling.
And crucially, the nursing considerations mentioned. Confidentiality and following reporting rules.
Absolutely critical. Strict confidentiality is non-negotiable. And nurses must know and follow their local, state, or regional protocols for reporting positive results to public health. That's vital for tracking and public health efforts.
Okay. Moving from blood tests to skin testing. This is common for allergies, right? How's it done?
Yes, skin testing introduces tiny amounts of suspected allergens to the skin to see if there's a local reaction. There are a few ways. Patch testing uses a pad on the skin. Prick or scratch testing involves a tiny skin break with the allergen applied. And intradermal testing injects a very dilute allergen just under the skin surface.
And the chapter stresses important steps before and after these tests for safety and accuracy.
Very important. Beforehand, you need a good medication history because things like systemic corticosteroids and antihistamines can block the reaction. They usually need to be stopped for about 5 days, as prescribed, and always get informed consent.
And afterwards?
Meticulous recording, where each test was, date, time, when to read it. And crucially, the patient must stay for observation, usually at least 30 minutes after injections.
Why so long?
Because of the risk of anaphylaxis, a severe reaction. That's the highest risk window. During the reading, the nurse looks for redness, bumps, blisters, swelling a wheal.
A wheal, like a raised bump.
Exactly, a raised, itchy bump. They measure the wheal and the redness around it. A wheal over half a centimeter is usually positive. Document everything. Provide a list of positive allergens. And always have resuscitation equipment ready just in case.
That 30-minute wait really highlights the potential danger. Okay, let's talk more broadly about hypersensitivity and allergy. An allergy is defined as an abnormal, exaggerated response to something usually harmless.
That's the gist. An allergen is the substance triggering it. And a key point from the source. The reaction usually happens on the second or later exposure, not the first time.
Ah, so the body has to be sensitized first.
Precisely. The first exposure primes the immune system, produces antibodies. Then the next time, bang, you get the allergic reaction symptoms. That's why skin testing helps identify those specific triggers.
So when gathering info about potential allergies, what do nurses look for?
A detailed history is key. Ask about exposures, timing of symptoms, what symptoms, itching, tearing, burning eyes or skin, rashes where, what kind, nose twitching, stuffiness, sneezing. linking symptoms to potential triggers.
And how are allergies typically managed?
Well, number one is identifying the allergen and avoiding it if possible. Then, managing symptoms with meds, antihistamines, anti-inflammatories, maybe corticosteroids for worst cases.
Topical treatments, too.
Yeah, for skin reactions, ointments, creams, cool compresses, soothing baths. And for some allergies, desensitization therapy or immunotherapy might be an option, gradually introducing tiny amounts of the allergen to build tolerance.
Okay. Now, shifting gears to something much more serious. Anaphylaxis. The chapter calls it a severe, immediate hypersensitivity reaction. What makes it so life-threatening?
It's the massive sudden release of histamine and other chemicals system-wide. This causes chaos. Airways can swell shut, making breathing impossible. Blood pressure can plummet, leading to cardiovascular collapse. It affects multiple systems fast.
And the priority nursing actions are absolutely critical, right? The source lists a clear sequence.
Yes, and speed is everything.
Yeah.
First, assess and maintain the airway, ADCs, instantly.
Okay, airway first, then.
Call for help immediately. Rapid response team, RN, provider, get oxygen on the patient right away. Help the RN get an IV started. Run a normal saline fast to support blood pressure.
And medicate.
Be ready to give them diphenhydramine, an antihistamine, and critically, epinephrine. Epinephrine is a lifesaver. It constricts blood vessels, opens airways, stops mediator release.
Got it. Epinephrine is key.
Absolutely. And then document everything meticulously. What happened, when, what you did, how the patient responded. Every detail matters.
Airway, call help, O2, IV access, epinephrine. Crystal clear.
Okay, now latex allergy. A specific hypersensitivity. What causes it?
It's a reaction to proteins in natural rubber latex, or sometimes the chemicals used to make it. Symptoms can range from mild skin irritation, like dermatitis, all the way to severe systemic reactions. Runny nose, itchy eyes, hives, bronchospasm, and yes, even anaphylaxis.
And box 59-1 lists common ways people get exposed.
A couple routes: direct skin contact gloves, balloons, percutaneous or parenteral IV tubing, catheters during dialysis, mucosal contact condoms, urinary catheters, airways, even bottle nipples.
And breathing it in.
Yes, aerosol exposure, often from the powder and some latex gloves, especially when putting them on or taking them off. The source also flags people at higher risk. Who are they?
Healthcare workers are a big group, obviously. Rubber industry workers, people with multiple surgeries. Individuals with spina bifida have a notably high risk.
Interesting.
Also, frequent glove users, like food handlers. And there's a known cross-reactivity with certain foods. Kiwi, bananas, avocado, chestnuts. Being allergic to those increases your latex allergy risk.
So when assessing for latex allergy, what signs are nurses looking for?
They're looking for a history of reactions after latex contact. Could be that immediate type I reaction, hives, itching, swelling, breathing issues. Or it could be a delayed type IV reaction contact dermatitis showing up 6 to 48 hours later with itching, redness, maybe blisters or crusting skin. Need to ask about the type of product and the reaction.
And box 59-2 covers the key interventions for someone with a known latex allergy. Seems focused on prevention.
Totally. Prevention is key. Ask every patient about latex allergy on admission. Document it clearly if they have it. Use non-latex gloves, and supplies facilities should have these readily available. Keep a latex safeguard handy.
Even for blood pressure cuffs.
Yeah, put a cloth barrier underneath. Use latex-free syringes, medication vials if possible, IV sets, and really reinforce the need for the patient to wear a medical alert bracelet and tell all providers, dentists, paramedics about their allergy.
Makes sense. Create a latex safe zone. Okay, let's talk about immunodeficiency. What's the core issue here?
Simply put, the immune system isn't working properly. It's either absent or not producing enough immune components like antibodies or cells. This leaves the person highly vulnerable to infections.
And it can be present from birth or develop later.
Right. Congenital or primary immunodeficiency is present at birth. Acquired, or secondary, develops later due to things like disease, malnutrition, or medications.
So when assessing someone, what clues might point towards immunodeficiency?
You'd look for factors known to decrease immune function, chronic illnesses, immunosuppressive drugs like corticosteroids, chemotherapy. A big red flag is a history of frequent, unusual, severe, or hard-to-treat infections, especially opportunistic ones. Infections caused by microbes that don't usually harm healthy people. Also assess nutritional status. Malnutrition hits the immune system hard. Get a thorough medication history, and ask about alcohol or drug abuse history, too.
And what's the absolute top priority intervention for these patients, according to the source?
Protect from infection. That's number one. Their defenses are down. So, meticulous infection control, hand hygiene, aseptic technique. Promote balanced nutrition. provide psychosocial support. It's tough news to manage. And educate about infection prevention, avoiding crowds, good hygiene, and wearing that medical alert bracelet.
Infection protection is paramount. Got it. Now, autoimmune diseases. Here, the immune system attacks the body's own tissues, right?
Exactly. The body fails to recognize self. It mistakes its own healthy cells for foreign invaders and attacks them, causing inflammation and damage. Our source covers several, starting with systemic lupus erythematosus SLE, or lupus.
And systemic means it can affect lots of different parts of the body.
Yes, major organs, systems. The chapter explains it involves deposits of connective tissue and fibrin in blood vessels, collagen tissues, organs. This causes inflammation and cell death necrosis in blood vessels, lymph nodes, the GI tract, the lining around the lungs, pleura.
Is there a cure?
No cure currently, but good management can lead to remission, periods where the disease is less active.
What causes it or triggers it?
The exact cause is unknown. Likely a mix of genetic susceptibility and environmental triggers leading to an immune defect. Potential triggers include certain meds, stress, genetics, sunlight or UV light, even pregnancy. There's also discoid lupus, mainly skin, sometimes drug-induced, which might clear up if the drug is stopped.
So what are the key things a nurse looks for when assessing someone for possible SLE?
You'd ask about those triggers. The classic sign is the facial redness, the butterfly rash or malar rash across the nose and cheeks.
Yeah.
Also, dry, scaly, raised rashes elsewhere, often face or upper body. Systemic symptoms are huge. Fever, weakness, malaise, fatigue, that's just overwhelming, poor appetite, weight loss, photosensitivity, reacting badly to sun, joint pain is very common. Maybe red palms, palmar erythema.
And lab tests.
Anemia is common, a positive ANA test, maybe a positive LE cell prep. Elevated ESR and C-reactive protein, those are general inflammation markers.
Wow, it can really manifest in so many ways. What are the main nursing interventions for managing SLE?
It's multifaceted. Monitor skin integrity, provide frequent oral care for mouth sores, use mild soaps, avoid harsh stuff, help with prescribed creams for rashes, address fatigue, identify triggers, teach energy conservation, pacing.
What about diet and meds?
If anemic, give iron, folic acid, vitamins as ordered. Encourage a diet high in vitamins, iron. High protein is good if kidney function is okay. Manage pain and inflammation with corticosteroids, salicylates, and SAIDs as prescribed. Monitor intake and output, daily weights, especially with steroids, watching for fluid overload.
And protecting from sunlight.
Absolutely crucial. Strict avoidance, sunscreen, protective clothing. Monitor urine for protein or red cell, cast signs of kidney involvement. Lupus nephritis, which is serious and can happen early.
Okay.
Watch for bruising or bleeding. Sometimes plasmapheresis is used, removing antibodies from the blood. Monitor constantly for signs of organ involvement, pleuritis, nephritis, pericarditis, etc. Provide supportive care for affected organs. And huge emphasis on emotional support, letting them talk, connecting them with support groups. Also, keep a close eye on BUN and creatinine for kidney function.
Definitely complex management. Okay, next up is scleroderma, or systemic sclerosis. How's this one different from lupus?
It's also a chronic connective tissue disease, systemic, involves inflammation. But the real hallmark of scleroderma is fibrosis, scarring, and sclerosis hardening and thickening of connective tissue. This happens in the skin, joints, esophagus, heart, lungs, kidneys, GI tract.
And the goal is similar, remission, slowing progression.
Yes, exactly. No cure, so focuses on managing and slowing it down.
What are the key assessment findings in scleroderma?
Pain, stiffness, muscle weakness. Often starts with pitting edema, especially hands and fingers. Then the skin changes are characteristic. Tight, shiny, hard, thick. It loses elasticity, feels stuck to underlying tissue. Dysphagia, trouble swallowing, is common from esophageal involvement. Decreased joint range of motion, contractures can develop, making daily activities hard. Raynaud's phenomenon is also very common.
Raynaud?
Where fingers and toes change color, white, blue, red in response to cold or stress.
Ah, right. So interventions for scleroderma.
Encourage activity as tolerated to maintain mobility. Keep the room temperature constant to help with Raynaud's and comfort. For swallowing issues, small, frequent meals. Avoid triggers like spicy food, caffeine, alcohol. Sit upright for 1-2 hours after eating. Provide supportive therapy for affected organs. Corticosteroids might be used for inflammation, but may be less effective than an SLE. And again, lots of emotional support and resources are vital.
Okay. Then there's polyarteritis nodosa, a collagen disease involving systemic vasculitis. What's a vasculitis?
Inflammation of blood vessel walls. In polyarteritis nodosa, it affects medium-sized arteries in organs, the brain, skin. Treatment is often similar to SLE suppress inflammation. It tends to affect middle-aged men more. Cause unknown, prognosis can be poor, kidney and heart problems are common causes of death.
What are the signs and symptoms?
Can be vague initially. Malaise, weakness, low fever. But more specific things include severe abdominal pain, maybe bloody diarrhea, weight loss. Elevated ESR is typical.
And interventions would mirror SLE management, focusing on inflammation and organ monitoring. Next is pemphigus. Rare autoimmune affects the skin.
Yes, rare affects middle-older adults. Autoantibodies attack the connections between skin cells, causing the epidermis to separate and form fragile blisters or bullae. It can be fatal, often due to infection or fluid electrolyte issues. Treatment aims to suppress that immune attack.
What does it look like on assessment?
You see these fragile, superficial blisters that rupture easily, leaving raw, weeping, crusting areas. It can be on skin and mucous membranes, like the mouth, causing pain, trouble swallowing. Nikolsky's sign is often positive. Rubbing normal-looking skin makes it separate. Labs might show high white cells, eosinophils, maybe a foul smell from lesions if infected.
Interventions must focus on skin care and preventing infection.
Absolutely. Supportive care is huge. Meticulous oral hygiene, encourage fluids, soothing baths, prescribed rinses, topical or systemic antibiotics for secondary infections. Medical treatment relies on suppressing the immune system, usually with high-dose corticosteroids, maybe other immunosuppressants, aiming for remission.
Okay. Then Goodpasture syndrome. Autoantibodies target membranes in the kidneys and lungs.
That's right. Specifically, the glomerular basement membrane in the kidneys and the alveolar basement membrane in the lungs. The antibodies bind, trigger inflammation, causing damage in both organs. More common in young adult male smokers. Cause unknown. Often diagnosed late when there's significant damage.
So assessment would show lung and kidney problems.
Yes. Pulmonary signs like shortness of breath, coughing up blood, hemoptysis. Renal signs like decreased urine output, blood or protein in urine, leading to edema, weight gain. Hypertension and tachycardia can occur too. Fatigue, malaise are common.
And interventions have to tackle both the autoimmune attack and the organ damage.
Exactly. Aggressively suppress the immune response corticosteroids, immunosuppressants. Plasmapheresis is key here too, to remove those attacking antibodies from the blood. Then supportive care for the lungs, oxygen, maybe ventilation, and kidneys, dialysis if needed.
Next is Lyme disease. This is an infection, but it has immune implications.
Yes, it's caused by the spirochete bacterium Borrelia burgdorferi, transmitted by infected deer ticks. The bacteria spreads, triggers inflammation, and can sometimes even stimulate autoimmune responses.
Box 59-3 outlines the stages. Stage 1 is soon after the bite.
Right? Early localized stage, days to a month after.
Yeah.
Sometimes you get that classic bullseye rash, erythema migrans, or EM, starts small, expands, but not everyone gets it. Or it can look different. It can show up anywhere. Also flu-like symptoms. Headache, stiff neck, muscle aches, fatigue.
And if untreated, it progresses.
Yes. Stage 2, early disseminated, weeks to months later, bacteria spread. Can cause joint pain, neurological issues like Bell's palsy, meningitis, nerve pain, even heart problems like Lyme carditis.
And stage 3.
Late disseminated Lyme, months to years later. Chronic arthritis, especially large joints like knees. Persistent neurological problems.
So interventions. Tick removal is important.
Crucial. Use fine-tipped tweezers, grasp close to the skin, pull straight up steadily, don't twist, clean the bite area. You could save the tick if needed. Blood tests for Lyme are best done 4 to 6 weeks after exposure. Earlier might be falsely negative.
But treatment starts sooner.
Often, yes. Antibiotics are usually started based on symptoms and tick exposure, especially if there's an EM rash, even before test results are back. And prevention education is huge. Avoid tick areas, wear protective clothing, use DEET repellent, check yourself thoroughly after being outdoors. Prompt tick removal is key.
Prevention sounds like the best strategy. Okay, shifting to acquired immunodeficiency syndrome, AIDS, caused by HIV, which destroys T cells.
Exactly. HIV, the human immunodeficiency virus, specifically targets and kills CD4 plus T cells, those crucial helper cells. Over time, this devastates the immune system, leaving the person vulnerable to opportunistic infections and certain cancers. AIDS is the late stage of HIV infection.
And it has a long incubation period.
It can be 10 years or more before AIDS develops. The person has HIV, but not the defining low CD4 count or opportunistic illnesses yet.
Box 59-4 lists diagnostic and monitoring tests, blood counts, lymphocyte panels, viral load, tests for infections. And the chapter reminds us of high-risk groups.
Yes, important to remember. Unprotected sexual contact with high-risk individuals, IV drug users sharing needles, recipients of unscreened blood products, mostly pre-1985, healthcare workers via occupational exposure, and babies born to HIV-infected mothers.
What are the key signs and symptoms a nurse might see in someone with AIDS?
It can be a wide range. General things like malaise, fever, anorexia, weight loss, flu-like symptoms, persistent swollen lymph nodes, lymphadenopathy for months, low white blood cell count, leukopenia, diarrhea, fatigue, night sweats. But the real hallmark is the opportunistic infections.
Like PCP pneumonia.
Yes, pneumocystis jirovecii pneumonia is a big one. Also neoplasms like Kaposi sarcoma, certain lymphomas, cervical cancer, fungal infections like thrush, candidiasis, histoplasmosis, viral infections like CMV, chronic herpes, bacterial infections like TB.
So, with such a weakened immune system, what are the nursing priorities?
Preventing and treating those opportunistic infections is key. Managing HIV symptoms, preventing further virus transmission, providing major psychosocial support. Interventions include respiratory support if needed, maintaining fluid electrolyte balance, constant monitoring for infection, using protective isolation if necessary. Strict standard precautions always. Comfort measures, meticulous skincare, crucial nutritional support to fight wasting.
The chapter then highlights Kaposi sarcoma, that cancer often seen in AIDS. What does it look like?
It's a cancer of blood and lymph vessel linings. Often shows up as skin lesions in immunocompromised people. Lesions are typically slow-growing, raised or flat, oblong, purplish reddish-brown, can be tender or not. Importantly, it can also affect internal organs, lymph nodes, lungs, airways, anywhere in the GI tract.
Nursing interventions for Kaposi sarcoma in AIDS.
Managing symptoms, preventing complications, support through treatment. Standard precautions are essential. Maybe protective isolation, if severely immunosuppressed. Prepare the patient for treatments like radiation, chemo, or immunotherapy. Comfort, skincare, pain management, and lots of emotional support.
Okay, finally, post-transplantation immunodeficiency. This happens because of the anti-rejection drugs.
Exactly. Transplant recipients take immunosuppressants for life to prevent their immune system from rejecting the new organ. But this deliberately weakened immune system means they have a secondary immunodeficiency, making them vulnerable to infections and some cancers.
So monitoring is critical.
Absolutely. Regular checks of overall health, function of the transplanted organ, kidney, liver tests, monitor CBC for infection signs, check body secretions for blood. Be aware that people with a history of cancer are at higher risk for recurrence, and recent exposure to things like TB, shingles, chickenpox puts them at high risk for severe disease.
Key nursing interventions for these post-transplant patients.
Strict aseptic technique is number one. Minimize infection risk. Massive emphasis on patient and family education. Signs of infection, signs of organ rejection, they need to know what to look for and report immediately. Ongoing psychosocial support for adapting to life post-transplant, and reinforcing everything about their immunosuppressant meds, why they take them, the exact schedule, side effects, the absolute need for lifelong adherence.
Wow, okay. This deep dive has covered a lot of ground from that chapter. We really went through the immune system basics, the different disorders, the tests, hypersensitivities like anaphylaxis and latex allergy.
Right, then immunodeficiency, whole range of autoimmune diseases, lupus, scleroderma, Goodpasture's Lyme.
Then AIDS and Kaposi sarcoma, and finally the post-transplant situation. Plus, the nursing focus throughout assessment, priorities, safety, interventions.
And those practice questions mentioned in the source, they really serve to hammer home those key nursing responsibilities in applying all this knowledge, like spotting early signs, prioritizing actions, infection control.
Absolutely. It's clear how complex the immune system is and how many ways it can be disrupted. Understanding these core nursing concepts, the assessments, the procedures, the safety aspects, the priorities, it really provides that essential foundation for caring for people with these conditions.
Definitely. And it makes you think, too, about how overall lifestyle and wellness factors might play into supporting a healthy immune system in the first place.
That's a great point for reflection. So with that, I think we can confidently say we have dug deep and comprehensively covered the key elements regarding immune disorders from this nursing review chapter, hitting all those crucial nursing concepts, assessment points, procedures, safety protocols, and priority actions. Thanks for joining us on this exploration.